Welcome to the Lane Gorman Trubitt Harvesting the Future webinar series. This 5-part webinar series will cover a wide range of topics that will help you in 2021 and beyond. Employee relations, budget changes, and retirement plans are a key part of your business. This series will help you understand what changes you may need to make for the future. LGT and Medical Auditing Solutions presents 2021 E&M coding changes in budgeting. This webinar will look at implementation and how it will impact your office. It was recorded live as a Zoom webinar on September 22nd, 2020, and all information was accurate and up to date at that time. There is a Q&A at the end, but if you have any questions, please feel free to email us at askus@lgt-cpa.com. Good morning, everyone. Thank you so much for joining us for this great healthcare presentation. We're really excited to have Angela Miller here from the Medical Auditing Solutions and our partner of practice growth, Lucas Lachance at LGT. A little bit about LGT. Lane Gorman Trubitt is a mid-sized accounting firm located in Uptown Dallas, serving businesses of all sizes. In 2020, we'll be providing you with endless opportunities for gaining CPE credit in different niches, including auto, construction, manufacturing and distribution, healthcare, not-for-profit, and real estate. Without further ado, I'm going to hand it over to Angela Miller to tell a little bit about herself and start her presentation.
Good morning, everyone. I'm Angela Miller. I have Medical Auditing Solutions as my business, and I've been working with Lane Gorman Trubitt to work with their clients on billing and coding audits and to help them with that particular function. I've had my business since 2005 and work on billing and coding issues. 80% of my work is defense work, but I do like to try to help providers be proactive and head off problems before they happen. So that's why we wanted to bring you this information today and talk about the E&M documentation changes as well as the reimbursement changes for 2021. So we're going to go ahead and start that. Hopefully I can work this because I'm a little bit challenged with, okay, I found it all. So we're going to learn what to identify. We're going to learn to identify the changes that have been made in the coding process. We're going to learn the importance of the areas that have been deleted from the coding consideration, learn the place of services that will be excluded from these changes, so not that it wasn't confusing already. We're going to discuss medical necessity and adequate risk. We're also going to conduct a plan for documentation to reduce risk that may be presented. You know, with anything that is new, when Medicare comes out with guidelines, there's always risk for interpretation of how that is to be implemented. So, as if evaluation and management documentation was not confusing enough, they have added more confusion to this. They have excluded localities, meaning if the patient has been admitted to the hospital or a SNF facility. History and exam is not considered part of the coding process anymore, but you will still need it in order to be appropriate and necessary. And we're going to talk about appropriate and necessary as we get into this presentation. Time alone can be considered now, not just when you're providing education to the patient. So we're going to talk about that as well. I want to talk about and cover the easiest part of this first. They have deleted your new patient E&M code 99201. If you have a 201, that is going to be a 202 now. The time associated with this, which is going to be important later in our conversation, is 15 to 29 minutes. Your new level 3 patient in-office procedure code is 30 minutes to 44 minutes. I'm not going to go through all of these, but this is a shortcut. I've tried to make a presentation as simple as possible because all of the materials and the webinars I've set in on have been 40 to 60 slides. So I'm trying to not go over past information and only give you what is pertinent as of this moment come 2021. That is subject to change come October. They have not finalized this process yet. So all of these codes have time specifically associated with them. One of the attachments that you will be getting a link to will be a sample evaluation and management chart note. It's one that I would suggest that you set up to include some of these areas, specifically a start time and end time for the provider. And we will talk about that a little bit more. They've also included prolonged service codes that are now billable in 15-minute increments. So that is a good piece that's come out of this. In the past, it was 30 minutes and I believe 60 minutes for the evaluation and management prolonged service codes. These are established patient E&M visits. You've got your level 3, your 4, and your 5, 20 to 29, 30 to 39, and 40 to 54 minutes. Time in 2021 is considered all face-to-face time and all non-face-to-face time on the day of the visit. Clinical staff time is not included. So this is important because your MAs may take a history, but the time does not start until the actual provider, the provider that is being billed and can be billed, starts to review the history that has been taken and start their face-to-face time with the patient. So they may be reviewing x-rays or tests. They may review the history. At that point, they can start the time. This can only be counted for one person per minute. So if the nurse practitioner and the physician see the patient at the same time, the time is only counted one time. So they can both be in there for 20 minutes. That's not a 40-minute time. It's only 20 minutes. If the nurse practitioner sees the patient 20 minutes and requests the physician to give an opinion to the nurse practitioner, and the physician sees the patient for 10 minutes unaccompanied, that time may then be counted as 30 minutes. So they have to be providing time separately to the patient and or reviewing tests, etc. So they can't be doing it together and count double. Preparation to see the patient, we just talked about reviewing tests, radiology reports, past visits, past medical history prior to walking in to see the patient. History, gathering and reviewing only the time done by the provider is counted. The history time taken by the MA is not counted, MA being medical assistant. You have the exam. You also have counseling, education, patient, where you're doing that with the patient or their family. Be sure to clearly document who is involved, who you're counseling and educating, whether it's the patient and their family, as well as writing any orders. When we get toward the end of this, I want to be sure that when we're capturing orders, we are documenting a complete assessment. If you have ordered test results or if your providers are ordering test results, the outcome of those test results, if made available at the time of the visit, should be documented, as well as a course of plan for the patient or a plan of care and direction for treatment. Referring and or communicating with other providers when not separately billable. Anything that is separately billable cannot count as time, because then that would be duplicating your codes. So we include on here independent interpretation of results. So if the provider is a sleep medicine and certified in sleep medicine, and they did an in-office evaluation and they're interpreting a sleep study, that time is billable under the sleep study code and not under the evaluation and management. So you can't count the time in both places. So that would be an example of that. Documentation of clinical assessment in the the electronic health record system. So where the provider is putting all of the clinical information is included in the time. So however long it takes them to document the history, within reason. I want to say within reason, because some of the systems are complicated, and I want to be careful that we are not using our electronic health record as an excuse to bill 50 or 60 minutes of time for every single patient. So even though that's included, we need to be careful about how we consider that. Any coordination of care when it's not separately billable. So if you're doing chronic care management, that would not be separately billable at this particular evaluation and management visit. If you are coordinating, now the patient needs home health, or they need other services, a referral to a cardiologist, those would be considered as part of that time, because you're trying to coordinate getting the patient the care and evaluation that they need based on findings at this particular visit. Excluded localities for the evaluation and management changes. Standard evaluation and management documentation still applies to any evaluation and management visit outside of the office or other outpatient services. So if you have a hospitalist seeing a patient in a hospital or an acute care facility, those would still follow the original evaluation and management documentation guidelines. So the history, the exam, and medical decision making, all three components will still apply. The exclusions would be hospital inpatient, nursing homes, in the patient home itself. So if they've been admitted, if you think about it kind of as a Part A billable situation, if they're considered inpatient, then those E&M documentation guidelines from the past would apply. Who does the rule apply to? It's in-office visit and other outpatient services provided by physicians and mid-levels. For any of those that are on the call, mid-levels would be a nurse practitioner, a physician assistant, a clinical nurse specialist, I believe is CNS. So if it is a mid-level that is billable and they have been credentialed with insurance or are allowed to bill independent, then that is who we're talking about. They can order, they have ordering privileges. So it would not be like a physical therapist. A physical therapist may have billable number, but they cannot write prescriptions. So if you think about it in the aspect of, can this provider provide a prescription for medication or services, then that is who it applies to. I would like to recommend, as we go into this, to continue to document all three of your sections, your history, your exam, and medical decision making, even though your medical decision making is going to be the only component counted on in-office and outpatient services. When you're documenting time, it will be crucial to have a start and stop time. If you are coordinating care, be sure to include that in your documentation, even if it's in your assessment. Refer the patient to Dr. Miller for a stress test, a cardiac stress test. I've educated the patient on appropriate eating due to obesity or diabetes. Make sure that you're documenting what your providers are doing. Ensure that they have information in their documentation to support the time. When we're billing time alone, your documentation still needs to support what you did. The rules do say you can code based on medical decision making or time. Time only needs to be supported by documentation. I'm sure that if any of you all have read the guidelines, you know that if you ask an attorney, if you ask 10 attorneys questions about the guidelines, you could potentially have 12 different answers. This is the same way if you ask a Medicare auditor. So you want to make sure that your documentation supports if you're billing by time only. Although history and exam are not considered in coding for 2021 in the office and outpatient settings, the rules state these history and exam must be appropriate and medically necessary. So to me, that's very subjective. And I think that that comes back to what does that really mean? Because what Dr. Miller does and what Dr. Williams do based on the same type of diagnosis may be completely different. So it is very subjective. So I want to emphasize that we need to document thoroughly. I would still document your history. I would still document your exam. And the better documentation you have for those, the more it will substantiate your medical decision making, which is going to be important in your coding aspect. The medical decision making will be the primary component for coding in 2021, unless this changes in October before it's finalized. Medical decision making still has the same components, and I think I put 4 and it should have been 3. Medical decision making is still determined in the same way. So the 3 components are the number of diagnoses that a patient has that are considered when treating and deciding the treatment plan of the patient. You've got the complexity, which includes what types of labs were ordered, what types of radiology, what types of medical tests were ordered, as well as obtaining old medical records and or history from someone other than the patient, reviewing old medical records and or making a summary of those, independent visualization of imaging as long as it's not separately billable. And then we have the risk component, which is the 3rd component of medical decision making. So all 3 of those components still apply, and it excludes anything that is not separately billable. I'm sorry, that is separately billable. The other part of medical decision making is this will be the primary component. So diagnosis, you want to make sure that your history is complete along with your present illness. Be sure to note any new, whether it's a new onset condition. Clearly note the status of the diagnosis. Technically, in order for them to be considered in the assessment and medical decision-making piece, there should be some sort of status to the diagnosis code at that point. Stable, controlled, persistent. I don't like the word stable. I think that Medicare auditors see that in a different way from medical professionals. Um, Medical professionals see that more as the condition hasn't gotten worse, but it hasn't necessarily gone away, and the condition may still be, it may still be chronic and ongoing, but it is stable at this point. So, you know, how the providers document that, it can be key in a post-payment audit, but making sure that you status your diagnosis on the patient is important. Whether they've improved, whether it's acute, it's chronic, it's a worsening condition. These diagnoses are going to be counted in your first section of medical decision making. So it's important that you document all diagnoses that are considered as part of your treatment plan with the patient, and whether or not the current condition can exacerbate any of the existing conditions that the patient may have, or maybe they have multiple conditions today as a chief complaint, but they also have other conditions that may be stable at this time, but due to the medication and or what the patient is going through, it could exacerbate some of those. So you want to make sure that you consider all of those and what we're considering in our head that we put on paper. So I know that this is going to be more documentation. In some respects, I think that they want to try to reduce documentation, but I think at this point, I don't want to say this is a shortcut. I'm afraid that the way it's been presented is going to cause risk in a post-payment audit as it moves forward until we have a little bit more clarification. And we're going to have history and exam in order to get to this particular point anyway. So it sounds like I'm saying we've got to document more, but compared to what they're saying in the rules, oh, well, you only have to do what's medically appropriate. Well, until you're audited, and then you try to defend yourself. So I want to keep that in mind as we go through this. And, you know, by the time we get to the end of Q1, if this is implemented to the way it's being directed now, we may change how we do things. But I think at this point, we need to be cautiously optimistic about how we proceed. So the second component of medical decision-making is complexity. You can count each unique test, and you want to count for all ordered and reviewed. So before, you got 1 point if you did a lab and you reviewed the lab. Now it appears to me that you can review the lab and have a follow-up order of the test, and you can count that as 2 points. So if I've interpreted this correctly, it appears this section, which most providers never really ended up with very many points in this section because of the way the points were to be counted. And if you don't have one of the old kind of Novitas audit tools, I can send the whole thing to you. But at this point, it looks like you can count that as 2. You order it and you interpret it, as long as it's not radiology, where you can bill the professional component of the radiology test, as an example. Unique medical records, that's 1 point per hospital record or doctor record. So that could be 2 now, whereas before that was, I believe, 1 point. So you're able to get more points here, which I think is good. Again, if you review old medical records, I would recommend that you make some sort of note, even if it is, I reviewed Dr. Miller's medical records. I reviewed records from Methodist Hospital in Richardson, Texas for this patient. The reason I say that is for 2 reasons. The more we have documentation, the better it helps us on medical malpractice, which is totally not connected to coding and billing, but it also helps you with the medical malpractice side. Plus, at this point, it helps you get points. If it's not in the medical record, if I'm doing an audit, I don't necessarily know that the doctor reviewed those, so I can't give them points. So I would document what I reviewed, and I would make it make it clear, since this is per record by provider. So the hospital record, not per admission, but per hospital, per doctor, you get more points that way. So be sure to document clearly so that you can be afforded the points moving forward that you deserve. Okay, I think I made that point. Okay, so risk of complexity, we continue to talk about that. Hasn't changed except minor wording. So where we're talking about the documentation, for instance, if we've got coders on the phone, and when we send out this link to the documents, you will see what I'm talking about. The risk for complications, for instance, if you have a low risk, you may have 2 or more self-limiting problems or 1 chronic stable illness. So your chronic stable illness may be hypertension that's well controlled. You're not having fluctuation in your blood pressure. Some of the other pieces of that would be non-cardiovascular invasive studies. So you have 3 different columns to pick from. But in this particular case, most of the wording stays the same. They've taken out some of the ambiguous terms, like I think they took out self-limiting, and I don't know the other one off the top of my head. So overall, this has stayed the same. They've tried to clarify some wording to make it a little bit more exact and not leave providers to go, well, is this really self-limiting, or is this really mild, or whatever. They've looked at some of that wording. Overall, it's still going to be the same type of decision-making protocol. The medication management. So one of the things on here, if you are reviewing the medication, be sure to note the drug, the dosage, the strength, and what it's prescribed for. That is the appropriate way to document it. So if you can pull those in together, that would be great, depending on how your electronic medical records is set up. Severe exacerbations or life-threatening it's life-threatening or pose a threat to the bodily function. If that is a case, I think that needs to be stated, whether it's a severe exacerbation. I have reviewed some medical records that, they look like the patient has an exacerbation until you get to the end of the record and it says, we called an ambulance and had the patient directly admitted to the hospital. So making sure that your chart note follows along with the patient, and if the patient is being admitted to the hospital from your office, make sure that it's clearly documented, because everything that you document, 1, helps coding, and 2, helps your medical malpractice position as well. Monitoring drug toxicity. This is one that falls into the high category, as well as severe exacerbations or conditions that are life-threatening and pose a risk to bodily function. Okay, so both of these are in high risk. These would be on the level 5 side if you've got your other 2 categories met. So this would be like Coumadin, psychotropic meds, where a provider has to run labs to ensure that the appropriate dosing is monitored so that the patient does not become toxic. When your providers, if you have providers that prescribe these types of drugs, it's important that that is clearly documented in the file, that you're running these tests. Make sure that if you run the test, that it's documented that the patient is on the drug. because that again goes to the level of coding that your provider can bill for that particular evaluation and management visit. Treatment above the E&M. So we're going to get into a couple of other things here that I wanted to bring up because of audits that I've seen and kind of add to what we're talking about. If your provider is doing something above and beyond what is covered in an evaluation and management visit, there are modifiers that apply. So if you're doing a pain injection and that is above the exam and it's above anything else that's considered, then you want to make sure you apply the modifier so you get the appropriate payment for that service that you're providing. If you're providing a breathing treatment because the patient came in and based on the exam of the patient, you decided that the patient needed a breathing treatment or some other type of test that is billable through the practice, so not labs that are sent out to LabCorp or whatever. If you're doing a neb treatment, make sure you apply the modifier. So this is really important for all your payers, not just Medicare. So I wanted to make sure that I brought that up because I've seen some issues lately where providers offices are forgetting to apply their modifier correctly. Likewise, if every single patient that comes into your office has modifier 25 on it, you will eventually be flagged for an audit. So make sure that your practice is applying those correctly, because that could come back on a post-payment audit. I'm not saying that it's bad, because if you're a specialist like a pulmonologist dealing with Medicare patients that have multiple comorbidities, that may be appropriate. Okay, so now we're going to talk about the reimbursement fluctuation come 2021, and Lucas is going to follow this presentation, and I thought this was good to work with Lucas on because budgeting is going to be a big issue. Q3, Q4 is when you budget for the next year. New patients, your level 2s and 5s are about the same. When I say about the same, they're like $1, less than $1. They're relatively same. Depending on what locality you're in, what state, that may vary a little bit, but I don't think it's going to vary a lot. So couple $3. Your level 3 is going to increase for new patients about $20. Your level 4 new patient is going to decrease by $30. So that's where we need to focus our conversation on this. Established patients 1 and 5 are about the same. 2 and 3 increase $50 to $20 respectively. Level 4 is a decrease by $20. Assessing quality of coding by level. If your bell curve for your office visits is more along the lines of level 4 and 5, your practice may suffer a loss if you don't take the changes seriously. So that's when I talked about, we really need to focus on your level 4s in your practice. The 5s are about the same, but level 4s are going to take a hit. Now they gave you raises on 2s and 3s, but if you have a specialty practice, again, that's dealing with Medicare patients with multiple comorbidities, you may not have as many 2s and 3s. As you can tell by the reimbursement, payers are seeing a lot of these codes and need to make it less appealing for providers. That's my opinion. That is not the opinion of LGT. So that is something that I've seen in post-payment audits for the last several years, is they're picking providers that have a lot of level 4s and 5s. And I think that based on these changes, that's they want to make this less appealing. I don't think that they really understand. I don't think providers for the most part are out billing everybody at a level 4 because they're like, oh gee, I want to get more money. I think that many of the patients that are being seen that go to the doctor frequently are probably much sicker patients and need more care. And that's why I feel like this is going to hurt providers, and it's going to hurt the patients in the process, because providers are going to lose money on level 4s. So we may end up having a webinar a little bit later with an associate of mine to talk about how you handle the documentation and the clinical aspect of this. So just keep that in mind. I think a lot of this is because of the audits that the payers have done and seen from the documentation from providers. So as long as we keep that moving forward, we understand why we need to document like we do, and continue to make sure that our documentation supports what we're billing. I would recommend that you get with your financial person or your CPA, Lucas, to help assess a budget for 2021, because I've talked to several providers that, if they're 50 to 60% level 4s in their practice, they're going to take a substantial hit from a revenue standpoint, and they need to be able to plan 2021 and how they're going to, how and if they can adjust their cost so that the revenue is not, the decrease in revenue is not going to hurt them financially. Okay, I want to talk a little bit about telemedicine. So we're covering a few different things in here, and we'll get to the Q&A in a little bit. Telemedicine. After COVID, most all the restrictions were waived in every state, every payer, Medicare. However, telemedicine is still audio and video. If you have a telephone call, that is a separate code and cannot be billed as telemedicine. I think that there's some confusion on that. You still have to document your telemedicine visit just like you would me coming to your office if you're a provider. If I'm coming to your office, you've still got to do the history, the exam, and medical decision making. So you've got to think about what part of the exam you can do by telemedicine. I know they've waived many of the restrictions from a HIPAA standpoint. That is only during this pandemic. They have said you can do FaceTime, and you can do a lot of other modalities or applications that were not previously allowed. I would encourage you to find a telemedicine company or talk to your electronic medical record provider to see if they have a telemedicine add-on function. Make sure that you have a template set up for telemedicine. This is going to be critical because I believe that Q4 and into 2021, we're going to see more audits on telemedicine. Doctors still have to take care of patients. I'm not against telemedicine. I think it's great. I think where we're going to see the problem is from a documentation standpoint, and the fact that providers are using telephone calls and potentially billing them as E&M visits, which you can't do. So, and if you've gotten something that says you can, make sure that you have a file folder called Telemedicine Rules and Regulations so that you can pull it out and refer to it in a post-payment audit. Okay, you need to have a thorough history. And the reason that I say that is because we're going to get into the medical decision making, and if we don't have a thorough history, since we're going to have a limited exam because you can only do so many things on telemedicine. You can visualize the abdomen, you can visualize the back, you can see them walking, but you can't necessarily feel if they have masses or other things. You can't touch the patient, so your exams are going to be limited. Think about what you can ask them to visually show you, if you need to assess their ability to walk because the patient has fallen, skin lesions, discoloration, wounds. What is the patient calling about? And think about what you can visually see from the patient. If you get the telemedicine add-on built-in piece, there may be some other functions that you can do, but right now during COVID, if you're using Skype for Business or if you're using FaceTime, you will have a limitation on what you can do because you can't get a blood pressure. You can't test their blood sugar, but you can do patient monitoring as something. If you're a primary care doctor or you're endocrinologist, if the patient has a diabetic monitor that uploads to the computer, that is something that you can look at adding that service into what you're providing to the patient. It won't be telemedicine, it won't be an E&M visit, but it is a separately billable code for electronic monitoring of whatever the service it is that can be downloaded and you can evaluate. I talked about, I think this is going to be an audit nightmare. I think it's going to be gravely important. I think because of the confusion that came out with the pandemic, again, anything that you have in your state, if you're not from Texas, make sure you keep any of the publications that came out. Today you do this, and that's at 9 o'clock in the morning, and this afternoon at 5 you do something else. Make sure you keep all of that, because I think there's a good 3 months in there from, early March until the end of May where the guidelines change so frequently on, yes, you can do it. Oh, we're going to waive this. They waived the restrictions, I know, in Texas to where a doctor can now order meds and other procedures or x-rays and that type of stuff via telemedicine. That had been a restriction, and it may be a restriction in many states. So when the pandemic is over, you need to prepare that telemedicine may not continue as it is at the moment, because they're going to have to rework some state pharmacy rules and state physician scope of practices, not just during the pandemic period. So make sure that you stay on top of the guidelines for that. Okay, this is another topic that I see quite often. Please, somebody beep in and tell me if I'm going over, because I could talk all day. Incident 2, the state scope of practice in your state may be different than insurance payer guidelines. Quick review on payer guidelines. The physician must see the patient first and develop a plan of care for that diagnosis and or condition. And for the follow-up visit, the physician must be in the suite on the follow-up with the mid-level. Okay. And the follow-up must be for the same condition assessed by the physician. So I want to go back here just a second. So the physician must see the patient. So the physician sees Angela for asthma. And I come back for a 30-day follow-up and I see the nurse practitioner. The physician must be in the suite when I see the nurse practitioner, not necessarily in the room, unless you're Texas Medicaid. Okay, so physician develops my plan of care. The nurse practitioner sees me to follow that plan of care, and the doctor is available in the suite, and I'm seeing the patient for asthma. If I go in for asthma and I have an upper respiratory infection, separate diagnosis, that means that my service has to be billed under the nurse practitioner that day, okay? So the only way it can be billed under the doctor incident to him is he develops the plan of care, the nurse practitioner, mid-level, whatever it is, physician assistant, clinical nurse specialist, sees me for that same condition, and the physician is in the suite that day. Okay. Any new conditions assessed by the nurse practitioner must be billed under the nurse practitioner. If the physician is not in the suite that day, he's on vacation, he's at the hospital doing surgery, that is another situation where you're meeting 2 of the 3 guidelines, but you have to meet all 3 to bill it under the physician. So a new condition or the physician billing, the physician being absent from the suite, it must be billed under the nurse practitioner. The reduction for billing it under the mid-level is between 8 and 15%. 8% for Texas Medicaid. Most of the payers are 15. There may be 1 or 2 that were 12 or 13%, but I would plan on 8 or 15. So in that case, if the allowed amount for calculation purposes is $100 for that service being billed under the doctor, and the nurse practitioner and patient don't meet all 3 criteria, then the allowed amount is then the allowed amount is then $85. Then the payer does their 80/20 off of that $85. So you've gotten it reduced by 15% because we didn't meet all of the criteria for incident 2. We're at $85, and then the payers are usually 80% of that $85. So I want to make sure that we have a clear understanding of this, because this happens, this question comes up a lot. If you are using a billing company, please make sure you're getting reports and you're making sure that the nurse practitioners are not being billed under the physician. Make sure you're getting reports periodically to review what's being billed. Credentialing. Oh, here we have a second question, true or false. State scope of practice is the same as insurance payer guidelines. Now, incident 2 also has another issue. All the mid-levels must be credentialed. Credentialing means that the insurance company recognizes them as a payer. Some insurance companies, you just fill out a form and say, Angela Miller, nurse practitioner, works at my practice. Some you have to credential just like you do the physician. Some of them do not recognize a nurse practitioner at all, and you have to bill them under the physician no matter what. So it's important that based on the state you're in, the payers you're dealing with, you know whether or not your mid-levels have to be credentialed with the payers. If they do, or if they have to be attached to the payer, because you have to send in like a form that says, Angela Miller, nurse practitioner, works here. I'm not a nurse practitioner, just using that as an example. That has to be done in order for incident 2 to be billed. Just over signing on the chart is not sufficient for incident 2 billing. What I mean by that is I've gone in to see nurse practitioner Williams, and nurse practitioner Williams has done my history, my exam, my assessment, orders. She signs off on the chart, and then Dr. Hootie Who comes in and he reviews and electronically signs off, or if they're still doing paper signs the chart as well. That is not sufficient for incident 2. We still have to meet all the other requirements in order for that to be valid. Texas Medicaid actually requires participation every visit by the physician to bill incident 2. So that means that the physician has to walk in the room, has to see the patient on every single visit in order to bill incident 2 the doctor. Okay. So I'm going to go back here for a second. On incident 2, I'm not a huge fan of incident 2. You have to have some really good staff. You have to have some really good protocol. and you have to have really good auditing procedures. If you're doing Incident 2 in your office, I would recommend at minimum a quarterly review. It doesn't have to be by an outside consultant, but you do need to set aside time for someone in your office to periodically review specifically the mid-level claims. This is very risky. I've seen billing companies that have billed mid-levels under the doctor and the doctor didn't know. That's why I insist that doctors review reports, that they get reports if you're using a billing company. Same thing in-house. That's the only way you know how your practice is doing, is to get reports. Charges, payments, adjustments, know where your practice stands at all time. Get that by provider. That way you know that nurse practitioner Williams and nurse practitioner Miller and nurse practitioner Thomas, what's being billed under them and what's not. If you've got mid-levels and they have nothing under them except you, then you have some risk there. If you're a multi-specialty clinic, and I'm talking, you've got multiple physicians and you've got multiple mid-levels, and you may see a patient for asthma, but you have another patient that another doctor that sees the patient for cardiology. You have to be really careful how you're billing Incident 2 in this particular situation. So I could talk about that all day. If you want to have a sideline conversation, we can do that. It's very risky, and I want you to take these guidelines back to your office, and hopefully you all can set up an audit protocol to at least review what you're doing. Okay, in conclusion, continue to document the way you've always documented. Your history, your exam, and those two documented completely and fully help support your medical decision making, which is where your coding is going to come from in 2021. But aside from coding, remember, all of your documentation helps you if you ever have anybody sue the provider for medical malpractice for some reason. So documentation serves two important pieces. Document more thoroughly than previously, because if you don't thoroughly document your history, which I see providers not doing that frequently, especially on their established patients, if your EMR shows you on the side of your screen, you have the side of your screen and it shows you all my history, and then you document the rest of it, but it doesn't show up in the chart note, it really can't count. You've got to pull it in on every visit so that it was reviewed and it can be counted. You can't go, oh, well, I went back and reviewed that, if you didn't really document that you did it. Include start and stop time for provider for the face-to-face and coordination of care. Okay, that is my contact information. And I also included 2 links for upcoming webinars unrelated to me about the same topic, because I'm sure that everybody's going to have a different opinion. Keep in mind, this may change come October. They're still working out some of the final details, but I think we need to plan for the worst and hope for the best. We're going to open this up for questions, I think. Do we have any questions, Katie?
At this point, there are none, but feel free to input those at any time, and we can circle back after Lucas's presentation and cover any.
Okay, I'm going to turn this over to Lucas and let him talk about budgeting and how this can impact you in 2021. Take it away, Lucas.
Perfect. Thanks very much, Angela. I appreciate it. All right. Thanks very much, guys. We really appreciate you hanging in there with us this afternoon. Angela brought a tremendous amount of information to the table about how billing and coding is going to affect your practice going into 2021. All of that has a direct impact on your budget for your practice. And so what we're going to talk about here are some fundamentals about budgeting, excuse me, I'm going to cover some of the basics. It'll be probably a good refresher for you. If you hear the word budget and realize that you haven't looked at yours or that you don't have one for your practice, there will be some great notes here about how you can start building one of your own. So we're going to talk about exactly that, building a healthcare operating budget. A little bit of information about myself. I'm a partner at Lane Gorman Truitt. I started with the firm in 2007. I worked actually initially in the audit department, and about 5 years ago, the partners figured out that I'm an accountant who can talk to people. And so now what I do is I spend a lot of time either expanding existing relationships within our firm and bringing new folks to the LGT family. And also I'm responsible for our firm's community outreach. So I'm a pretty visible person. And this is a little bit about my background. I would be happy to answer any questions for you if you have anything as we get into the presentation. So just be, like Katie said, be sure to put those into the chat function. So let's dive in then on a back to budget basics. There are a variety of methodologies that you can choose when you're building a budget for your practice. We're going to talk about a couple of them and then some of the pros and cons of each. So you can start with incremental budgeting. And what that does is it takes last year's performance, the actuals for your practice, and then you apply it usually a percentage based on what you know about what's happening in the industry. So it may be that you're expecting growth for your practice, or it could be that your practice is in a period of contraction, and so it might actually have to back off what your estimated revenue numbers are going to be for the following year. But what you do is you figure out what that delta is. Are you planning on business expanding or contracting, and what kind of percentage that is, and then you apply that to your budget. So if you've got a decrease in revenue, you're going to want to see a corresponding decrease in your expenses. Otherwise, you start eating into your profit. So the incremental budgeting process is really, it's a very simple way to start. Some of the pros are that it's simple and it's easy to understand. It's very mathematically driven. So if you decrease your revenue by a factor of 10%, you should expect at least a commensurate reduction in expenses by that amount. And it's good when your cost drivers remain constant. When you have a lot of fixed costs, when you don't have a lot of variable costs that are sales related, it's a good basic foundation for building a budget. The cons though, and you have to keep in mind that there are some cons with this. When you are not doing a deep dive on your specific cost drivers, on your expenses, and you utilize incremental budgeting, you really have an option or an opportunity there to perpetuate inefficiencies, because it doesn't really force the leaders of the practice to look for ways to cut costs or economize. It creates budgetary slack by incentivizing leaders to overstate their needs. So if I'm building a budget and I say that I need 25%, or that my expenses are going to be 25% for my particular aspect of the practice, then if I really know in my heart as the leader of that portion of the practice that my expenses are really only 25%, I'm going to overstate my expenses to show that every year I'm coming in under budget every year. It also ignores external factors in the supply chain that can drive activity and performance. And here, I would consider taking a look at what's going on right now with the pandemic. I mean, it's difficult to realize that no one really could have foreseen how this was going to impact us. But if you're in a medical practice and you need PPE, at this point, you either have to pay a premium for it or you may have to do without it at all. And those disruptions in the supply chain that drive your activity and performance, that has an impact directly on your practice. When you have to pay higher premiums, it makes than budgeted for essentials, that also eats into your profit for the practice overall. Okay. Activity-based budgeting, that's when you start with a target number for revenue, and then you determine the related expenses that drive that revenue for a specific profit margin. So if you're going to say that I want there to be $5 million in revenue for the practice this year, what are the activities and what costs are going to fall in line underneath that to drive that revenue? This methodology is usually driven by historical data, and that generally is very easy to obtain. If you've been budgeting or monitoring your spending over the last couple of years, You can data mine through your accounting system and pull out the key data that you need to be able to build a budget like this. It also helps to drive additional key performing metrics or key performing indicators like revenue per patient. When you're data mining that data from your accounting software, you're going to have to you'll be able to data mine the other additional information that you need. Let's see, some of the cons. This is easy to divorce cash flow from revenue. And there's a difference if you haven't had an opportunity to refresh on some of the accounting terminology in a while. Revenue is good, but that doesn't always necessarily equate to the amount of cash coming in the door. It also makes it difficult to do a course correction when you have a problem with your cash flow and your revenue and your expense drivers. So it's got some cons that you have to be aware of as well. Next up is value proposition budgeting. That centers around 3 key questions when you're creating your budget. You look at each aspect of your budget and you ask, why specifically is this included in the budget? Does it create additional value for the patients, staff, or the owners and stakeholders? And does the value of what that aspect brings outweigh its actual cost? If it doesn't, then you have to consider, is there another reason that cost could be justified? So a lot of the costs that we look for here are administrative in nature. When you're making investments in the environment of your practice, that isn't always necessarily something that brings in new clients or brings in new patients. But what it does is it provides an environment for your staff where they want to be, which decreases turnover and other administrative expenses like that. So having this as a value proposition can be difficult, particularly when you come to aspects that are not specifically derived from patient care. The old adage here is very true as well. One man's trash is another man's treasure. So this is a very highly subjective approach to budgeting. And ultimately, the final arbiter on whether or not that expense gets approved lies with whoever holds that particular power. So relationships come into play, favoritism comes into play, or if the person who's making the ultimate decision doesn't see the value the way that you do, that as a practice leader, that could be a problem, because ultimately someone has to make a decision on whether or not those expenses get approved. And if your pet project that you feel adds value isn't approved and is on the chopping block, then you have to sway the person who holds that power. All right, and then moving on. Zero-based budgeting. Now, this is my favorite methodology if we're talking about a budgetary approach. It starts with the assumption that everybody's budget is $0 and it needs to be rebuilt every year. So you have to take a look at what your goals are, either as a practice overall or as a business leader or specialty leader within the practice. You have to determine what your goals are for the year and then build your expenses to justify that revenue. There are lots of pros to this. It's an extremely tight process. It focuses everybody on what are essential costs for the practice. What do we have to have in order for the practice to be successful? It trims out a lot of fat, which is good. It's an excellent format for budgeting when there is a need for cost containment. Often in times of financial restructuring, if you're looking at an acquisition, or if you're in the middle of a global pandemic, when costs are important, this is a great budgeting tactic to apply. Like I said, it frequently weeds out discretionary costs and carves out some of the fluff from a budget. The major drawback with this, though, is that essentially every year you wind up reinventing the wheel. This methodology is excessively time-consuming. I would not recommend using this every year. This may be good for every couple of years, every third or fourth year, to really do a deep dive on what comprises your expenses. But having to build an entire budget to run a practice successfully every year is going to be incredibly time consuming. You'll have folks the leaders in your practice and your practice administrators will be bogged down with a lot of administrative time focused on the budget if you have to do this process every year. Okay. Some other budgeting methodologies. So each of the ones that we talked about, they fall into or can be classified as 3 different main types. And it could be that it's an imposed budget, which is a top-down process. That's where the stakeholders or the owners. Let's see, we've got something in the chat here real quick, which I can't see. So it's imposed budgeting is top down. So that's when the stakeholders or the owners, they set the parameters, they set the framework, and then enforce that down through the rest of the practice. So that managers and staff need to implement what the owners and stakeholders say are the important initiatives. Negotiated budgeting, that's kind of your middle ground. It's a blend between a top-down approach and a bottom-up approach. It's often driven where you've got management or where you've got stakeholders and owners that say in very broad terms, we anticipate this type of revenue, I want to see these types of activities take place. But a lot of how the budget is spent is informed by input from managers and staff. So a lot of it is owners who, especially in a large practice, may be removed from the day-to-day experience of running the practice. And this is a great approach for negotiated budgeting where owners can rely on input and feedback from the management and staff that are in the practice running it every day. Then there's the participative budgeting process where staff and managers make recommendations to business owners and executives and stakeholders. That is also a great approach to a certain degree because what you'll have certainly is you'll have buy-in from the folks that are managing the practice on a routine and daily basis. If they're participating in the process itself, then they're automatically engaged with things like cost control, monitoring expenses. The problem with that, though, is that not always do managers and staff and practice leaders see the long-term plans of the practice the way that stakeholders and owners do. And so sometimes there can be a disconnect. I have found in my experience, your best approach is one that's negotiated, where the owners and stakeholders can help drive the practice forward and understand what the long-range plan is, whether that's an acquisition in a couple of years, if it's the eventual sale of the practice. Those long-range plans need to be supported by short-term goals. And I think negotiated budgeting is a great place where both of those things meet. Okay. All right, so we're gonna move on. We've got a little bit more ground to cover and we're gonna run right out of time. I'm sorry, guys. Okay. So we've got some controls to prevent and detect potential financial statement fraud. I pulled this from another presentation that I do on fraud prevention because there are 4 key bullet points here that all relate to budgeting, and I wanted to let everybody to know that these are some areas that you need to watch. When you have a budget, it shouldn't be something that an exercise that you go through once a year and then put it on the shelf. You should be reviewing your budget to actual performance on a monthly, quarterly, and annual basis. Now, monthly doesn't have to be a deep dive. You can look for fluctuations that are significant, but quarterly and certainly annually, your budgeting process needs to be looked at in detail. You can also compare your current year performance to prior year performance for the practice, year to date, as well as what are your anticipated revenue goals and expense goals compared to prior year. And then understand too that as the practice administrator, you may have a very thorough understanding of financial statements, but not everybody on the management team shares that same level of familiarity with it. So just make sure that as a practice leader, you understand the financial statements and that the rest of the management team does as well. Another great thing to do is distribute and discuss the financial reporting with staff. Again, this is critical when it comes to buy-in. If you want the entire staff to be involved in financial control, they need to have information about how the practice is doing to be able to do so. Lastly, another one that I really love is flash reporting and dashboarding. I'm a very visual person, so having a dashboard where I can see key metrics that are important drivers for the firm available to me, graphically represented rather than just in the form of a balance sheet or an income statement, that is also very meaningful. We've hit a break in the presentation. I have, beyond this, I have a 12-step plan that is building your own budget. I will actually, this presentation will be available after we wrap up today. I'd like for you, if you have any questions as you're reviewing it, please don't hesitate to reach out to me. My contact information is included on that second slide, email and phone number. So as you're going through and reviewing your practice's budget, or building one for the first time even, this 12-step plan on BYOB will be very helpful for you, and I'd be happy to be a resource at any point as you're going through the process. Katie, it looks like we have come up against our time, so I'm going to turn it over in case there's any housekeeping that you'd like to address before we sign off for the day.
Awesome. Thank you so much, Lucas.
Sure.
And Angela, those were two great presentations. As always, if you have any questions about this presentation, if you want to send a follow-up to Lucas or Angela, you can feel free to email us at askus@lgt-cpa.com, and we will get back to you as soon as possible.
Thank you, Katie. Appreciate it.
Thank you, Lucas. Thank you, Angela. Everyone have a great day. Thank you for joining us. Please make sure to follow our events page for more information. The link is in the description below, along with other important links, including our social media. If you want to see more of the Lane Gorman Trubet Harvesting the Future webinar series, subscribe below and hit the bell icon for notifications.